Hi everyone. Good evening to all of you. Today is again yet another osmosis we are organizing, and this time we are talking on ovarian cancer. Today we have Dr. Jogmaya Patnaik, Dr. Sushant Kumar Paikare, Dr. Jaideep Ghosh as a speaker as well as our moderator, and we have number of panel members today to discuss few case studies. So with that, we are extremely happy and we are extremely excited to start the yet another scientific discussions on ovarian cancer. And as you know that this is the 14th osmosis in the since last year we are conducting with number of good attendees. And with that, I would request our medical team, one of our medical team, Miss Anjana, to start with a brief of agenda. And with that, we can start the meeting. So thank you very much. Over to Miss Anjana Yadav.
Okay. Thank you so much, Saurabh. I once again welcome everyone. Good evening, everyone. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana Yadav from the medical team of Samarth Life Sciences Private Limited. On behalf of the organization, I am delighted to welcome all of you for today's webinar that we refer to as Osmosis. Now, what is this Osmosis? It is a scientific initiative by our oncology division, that is OnQuest. In this activity, Samarth as an organization aims to provide scientific platform to discuss on various topics which are related to oncology specialty. We therefore believe that Osmosis is not just a scientific platform, but it is also a platform for that provides a powerful metaphor for knowledge dissemination. This process of knowledge updation is very crucial, especially in the ever evolving field of oncology, where there is continuous learning and adaptation are essential for improving the patient outcomes. Today's program is also a testament of our collective commitment to staying at the forefront of medical advancements and providing the best possible care to our patients. The focus points for today's discussion will be the role of PARP inhibitors in ovarian cancer. We are fortunate to have with us esteemed experts who will share their insights and experiences on this topic. Before we start, let me give a brief about our company profile, that is Samarth Life Sciences. Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Since its inception in the year 1963 by Mr. Gunwant Lal Shah, Samarth Life Sciences has been a prominent player in pharmaceutical industry. Samarth Life Sciences operates through 14 therapeutic specialty divisions, each focusing on specific areas of healthcare to provide targeted solutions and expertise across a broad range of medical conditions. OnQuest is one of the divisions that caters to the oncology specialty. Samarth Life Sciences is WHO GMP and ISO 9001 certified, that ensures the highest standards of quality and manufacturing practices. We export over more than 2,250 products in over 70 countries, demonstrating our global presence and commitment to serve the diverse market. We are also proud to share that Samarth Life Sciences has received significant accolades and recognition, reflecting its excellence and influence in the healthcare sector. With this short brief about us, we would like to initiate the scientific program. For this, I would again like to introduce the program director, Dr. Jogmaya Patnaik ma'am. Dr. Jogmaya Patnaik ma'am is a medical oncologist at KIIMS Cancer Care, Bhubaneswar. She will enlighten us by delivering a talk on the use of PARP inhibitors in ovarian cancer, followed by two case presentation, which I will introduce later. But as of now, I would like to hand over the session to Dr. Jogmaya Patnaik, ma'am, to take it further ahead. Over to you, ma'am.
Thank you. Thank you so much. Thank you, Samarth team, first for being so active in dissemination of medical knowledge, which is so essential for medical oncology or the oncology field. So I'll just share my slides.
Yes, your slide is visible, ma'am.
Okay. Thank you. I'll start my presentation. So my topic of today's presentation is PARP inhibitors in ovarian cancer. Ovarian cancer is a common malignancy in females that we see, and day in, day out, we see ovarian cancer cases. And it's a very difficult malignancy to treat because it has, though it has multiple treatment options, but most of the cases patients present usually in later stage. And we have multiple options of treatment. And by using those multiple options, mostly we try to improve the progression-free survival and overall survival of this group of patients. PARP inhibitors are the latest addition in the armamentarium for the treatment of ovarian cancer. So ovarian cancer actually is the 5th leading cause of cancer in women, despite only 1.1% of all new cancer cases. But it is the 5th leading cause of cancer death. Why? Because most of the patients, they present in the later stage, and recurrence rates are very high. When they present with stage 3 or stage 4 diseases, the recurrence rates are really high, even after the first line of treatment. So the 5-year survival is maximum 50%, and 30% patients present to us with distant metastasis, and 57% of the patients are diagnosed to have at the time of presentation at least distant or recurrent disease or metastatic disease. It's mostly seen in the elderly population, and mostly more than 10,000 cases are diagnosed every year in India, with a very high rate of recurrence. Stage 3 cancer patients will have at least 70 to 80% recurrence rates within 2 to 3 years time after the primary treatment. With stage 4 patients, their survival is overall very dismal, with 5-year survival of almost less than 20%. So mostly we treat this group of patients with, if they present with stage 3 or stage 4 disease, mostly their first plan of treatment is chemotherapy. Mostly we use platinum-based chemotherapy, followed by, if there is good response, then a cytoreductive surgery, followed by adjuvant chemotherapy. After that, now there is a lot of data for PARP inhibitors. If there is HRD or BRCA positive, then we go for the maintenance therapy. So what is the PARP inhibitor, role of PARP inhibitors? So mostly in our DNA, every day some single-stranded or double-stranded breaks, they happen, but they are actually repaired. So single-stranded breaks, they are repaired by a enzyme system called PARPs, which repairs them. When PARP is not there, then the single-stranded breaks, they keep on accumulating. And when there is accumulation of single-stranded breaks, then later on it becomes double-stranded breaks. So normal cancer cells, with the presence of they repair themselves by homologous recombination process, and there is survival. But cancer cells which have homologous recombination defect, so there is no repair pathway. So because of that, tumor-specific killing occurs by PARP inhibitors, and that causes cell death. So it is a tumor-specific killing. So those cancer cells which are HRD deficient, they will not be able to repair the double-stranded breaks, and therefore cell death happens. So if we see alterations in homologous recombination defect occurs in serous ovarian cancer almost 50% of the cases. So commonly we see BRCA1 and BRCA2 mutations. Germline BRCA1 mutation occurs in 8% cases and germline BRCA2 mutation occurs in 6% cases. Along with the BRCA mutation, there are other deleterious mutations which also happens, and this is combined as a HRD. So this HRD comprises not only BRCA, there are many genes associated with this, RAD, CHEK, MET. So all these various genes are POL. So many genes are associated with this, and they are mostly associated with defect in mutations, deletions, amplification, and promoter methylations. So in this way, we divide them into the ovarian cancer into either homologous recombinant proficient or homologous recombinant deficient. They're mostly 50-50%. So from mid 2010-15 onwards, we had the options of using platinum-based chemotherapy followed by some maintenance in the ovarian cancer treatment. Earlier, we were using bevacizumab. After the entry of the PARP inhibitors, we are using now various PARP inhibitors as a maintenance therapy. So in December 2018, olaparib came. Then from 2020, olaparib plus bevacizumab came. Niraparib came. Then rucaparib came. So all this, we have actually three PARP inhibitors. One is olaparib, one is niraparib, one is rucaparib. So all these are important for our armamentarium for PARP inhibitors. So first trial is phase 3 SOLO-1 trial. So in this, olaparib is used as the first line maintenance in advanced ovarian cancer after CR and PR after the platinum-based chemotherapy. In this, patients who are newly diagnosed with FIGO stage 3 and stage 4 high-grade serous or endometrial ovarian fallopian tube or primary peritoneal malignancies with BRCA mutation, they have undergone cytoreductive surgery and they have been either in CR or PR after platinum-based chemotherapy. They were used either olaparib or placebo for next 2 years. In the SOLO-1 or 7-year follow-up data, overall survival benefit was there, and the overall survival benefit was in placebo. 44% patients received subsequent PARP inhibitor therapy, and the hazard ratio for treatment was 0.55 in this group of patients. There were multiple side effects in olaparib group: nausea, fatigue, asthenia, vomiting, anemia. These were the complications in olaparib group. In placebo group, there were less complications. Higher grade 3, grade 4 complications were seen in the olaparib group compared to placebo group. So, SOLO-1 data should be considered the standard of treatment for women with newly diagnosed advanced ovarian cancer and a BRCA mutation. BRCA status should be assessed in all patients with ovarian cancer at diagnosis. But what about the BRCA wild type patients? So there was a study called PRIMA study. They showed that maintenance of niraparib versus placebo in ovarian cancer at high risk of recurrence after the first line of treatment. This was a double-blind placebo-controlled phase 3 trial in which newly diagnosed patients with ovarian cancer with good response to first-line platinum-based chemotherapy, and they're at high risk of recurrence. They were, after the neoadjuvant chemotherapy, they were randomized to either niraparib maintenance or placebo maintenance, but the treatment continued for 3 years or until progression or unacceptable toxicity. In these patients with HRD were taken, and the randomization was the stratification was done on HRD positive or HRD negative. So in this, we had the PFS in HRD population, where the median PFS was 24.8 months in the HRD population, and 19.4 months in the HRD negative population. In the overall population also, the HRD was better in the patients who had niraparib maintenance. So then later on, there was an evidence whether the VEGF inhibition and the PARP inhibitor could be combined. So if we combine the VEGF inhibitors and given as a maintenance, as we have seen in GOG 218 trial, after completion of chemotherapy, if we do not give anything versus bevacizumab maintenance, then definitely there was a benefit with the bevacizumab initiation and bevacizumab maintenance. So the Paula 1 study had shown that if the patients could be given along with bevacizumab, the patients can be given PARP inhibitor maintenance, then their PFS further improves. So in Paula 1 study, which was a phase 3 trial, in this high-grade serous endometrioid, ovarian or fallopian tube or primary peritoneal cancers were taken. Those who had CR or PR after the primary treatment, and they have at least received more than 3 cycles of bevacizumab. Those patients were given olaparib 300 milligram BID and bevacizumab 15 milligram per kg on day 1. The other arm was given only bevacizumab, and after that the bevacizumab could be continued up to 15 months, and olaparib could be continued up to 2 years or until progression. In the overall population, HRD positive was HRD or BRCA positive were 19%, or only BRCA positive were 29%. Total 48% patients were HRD positive and 34% patients were HRD negative. The primary endpoints were PFS2 and overall survival. And all patients in this trial were evaluated for HRD testing using the Mirrors My Choice testing. And after that, they have found that there is benefit for PFS benefit for olaparib plus bevacizumab maintenance. The median PFS was 46.8 months in the olaparib plus bevacizumab group compared to only placebo plus bevacizumab group. And 5-year PFS rate was 46% in the olaparib plus bevacizumab group, and placebo plus bevacizumab group had only 19% 5-year PFS rate. So depending on this, the Paula 1 trial, olaparib and bevacizumab is the current standard of care for HRD positive patients who are given at least 3 cycles of bevacizumab during the primary treatment before the maintenance. At least the patient should have received minimum 3 cycles of bevacizumab. So the overall survival was also a trend towards benefit was there. 56.5 months was the median OS in the olaparib arm compared to 51.6 months. They were not they were numerically better, but the hazard ratio was not encouraging. But definitely there was a trend to improvement of overall survival. So the final results, when they have seen the 5-year overall survival, that was 65% of the 5-year overall survival in the olaparib plus bevacizumab arm compared to only placebo plus bevacizumab arm. Upon the disease progression, 17% and 51% in the olaparib plus bevacizumab arm and placebo versus plus bevacizumab arm respectively received a PARP inhibitor during any subsequent treatment. So crossover was allowed in this group of patients. So side effects, if we, the most common or the important side effects we always as medical oncologists care about the PARP inhibitor are anemia, cytopenias, fatigue, and the future risk of MDS, AML, or aplastic anemia. In olaparib plus bevacizumab group, there was 6% chance of development of MDS, AML, and in placebo bevacizumab group, it was negligible. So this was important thing which always be taken into account, that there is some 5% risk of development of MDS, AML will be there. So definitely we have to be very watchful about this. There is also data for maintenance rucaparib according to the Athena mono trial after the first line platinum based chemotherapy in advanced ovarian cancer patients. This was also a phase 3 trial in reported or the data cutoff was done in 2022. There was four arms in the Athena mono trial. They had patients with high-grade advanced ovarian cancer patients who have at least received their platinum-based chemotherapy and cytoreductive surgery, achieved CR or PR, and good performance status. And they had 4 arms: rucaparib 600 milligram BID plus nivolumab, rucaparib 600 milligram BID plus placebo, placebo plus nivolumab, and arm D, which was placebo. It was only placebo, IV and oral placebo. So basically, the current analysis which was done between the Rucaparib, between the arm B and the arm D, that means the Rucaparib maintenance and the arm D. So they found the primary endpoint was investigator-associated PFS. Secondary endpoints were OS, investigator-associated overall response rate, disease control rate, etc. So in the intention to treat population as per the primary evaluation of the primary endpoint, which was PFS, they found that median PFS of Rucaparib arm was 20 months compared to placebo, which was only 9.2 months. And in all the evaluations over around 36 months or around approximately 3 years, the Kaplan-Meier curves are seen to be separated from each other. So in this, definitely, it significantly improved the investigator-associated PFS versus placebo, and it is also currently a point of recommendation. And if we see, this trial was not with particular HRD population, but they have stratified whether HRD positive or HRD negative population is there. They found that the HRD positive population, the benefit was much better compared to the HRD negative population. Side effects, if we see, all olaparib drugs, they have the common side effects as anemia, asthenia. They are the common side effects. More than 50% of the people mostly have, but more than grade 3 or grade 4, mostly less than 5% patients. So mostly it is well managed with IV iron or oral iron therapies. Around 30-40% patients, they will have liver function derangements. That is also mostly managed conservatively and doesn't cause much problem. Then the summary of guidelines for PARP inhibitors for first-line maintenance therapy of ovarian cancer is that when a newly diagnosed patient of ovarian cancer comes, we first give platinum-based chemotherapy. Patient undergoes surgery, and if develops or has CR or PR after the platinum-based chemotherapy, then according to the HRD positivity or BRCA positivity, we divide. So if germline or somatic BRCA1, BRCA2 mutant patients are there, we can give niraparib, olaparib, and rucaparib combination as per the PRIMA trial, SOLO-1 trial, and the Athena mono trial. HRD positive can also be given maintenance based on niraparib, and if HRD positive is there, as per PAOLA-1 trial, we can give olaparib or bevacizumab maintenance up to 2 years in and the niraparib, rucaparib also they can be given up to 2 years. BRCA negative or HRD negative, data is only there for niraparib and rucaparib. So we have also pulled data for study 10 and aerial 2 trial. And the study population for this group of patients, there was the criteria was a diagnosis of ovarian cancer, and they have at least seen they have at least taken rucaparib and received more than 1 dose. And the criteria was they have received at least more than 2 prior chemotherapies, including 2 platinum-based, and had a deleterious germline BRCA or somatic BRCA mutation. And in study 10, they had 62 patients on rucaparib. In aerial 2 trial, they had 315 patients. And there were 2 parts. One is safety population, another is efficacy population. So 2 sets were divided. And they found that objective response rate in patients with somatic or GBRCA mutated patients, it was almost 54%. Complete response rate was 9% and partial response was 45%. And median duration of response on the patients who had continued on rucaparib was 9.2 months. So, so the rucaparib activity, if we see in HRD or non-HRD patients, with BRCA or BRCA-like signature or LOH high, 30% overall response rate, and 50% of the patients were still continuing on treatment. Patients without BRCA or BRCA-like signature, 13% ORR was there. In LOH patients also, or BRCA-like signature also, they will respond to PARP inhibitors. So therefore, in LOH or BRCA-like signature patients also, rucaparib or PARP inhibitors, they work. So as for the subgroup analysis and median overall survival in this group of median PFS into this group of patients, if we see the BRCA versus BRCA low patients, there is definitely BRCA positive patients, the hazard ratio is much better. BRCA LOH high versus BRCA LOH low also it is better. That means high LOH patients also they respond and they have a good median PFS along with rucaparib maintenance. This is as per the aerial trial. So there is another trial for role of recurrent ovarian cancer patients. There is also data for use of rucaparib, niraparib, and olaparib. We have good data for platinum-sensitive recurrent ovarian cancer for olaparib also. This aerial 3 patients, they had high-grade serous or endometrioid or epithelial cancer patients. They are sensitive to platinum or recent use of platinum. Those patients were random without any PARP inhibitors with good performance status. They were randomized to 2:1, and stratification was HRR status by NGS, BRCA1 or BRCA2, non-BRCA or HRR gene were seen. Response to the recent platinum treatment like CR or PR was seen. Progression-free survival after the penultimate platinum less than 12 months or more than 12 months. And they were given rucaparib 600 milligram BID or placebo was given. This was a 2:1 randomization. Then, sir, the analysis cohort, they had HRD positive and HRD negative population. So the PFS, when it was seen in the rucaparib arm, in the BRCA mutant patients, it was 16.6 months compared to 5.4 months in the BRCA negative, in the patients who did not receive olaparib. In HRD positive patients also, the Kaplan-Meier curves were widely separate. And in HRD, in the intention to treat population, in the intention to treat population, in the entire population or the entire intention to treat population, median PFS of the rucaparib arm was 10.8 months compared to 5.4 months in the placebo arm. So in LOH high population also, rucaparib has a median PFS of 9.7 months compared to 5.4 months. In LOH low, mostly the difference was less, but numerically it was significant. So exploratory analysis also, this has shown LOH high patients, BRCA wild type with LOH high patients, rucaparib maintenance was associated with better progression-free survival compared to LOH low group. So the aerial safety analysis was 100% of the patients had at least some events or grade 3 side effects were almost 50% patients had. Dose reduction was some dose reduction due to adverse events were done almost 54% of the patient. Treatment interruption was 63% of the patients due to adverse effects or side effects, but discontinuation was only 13% of patients. So, so common side effects, as this is a class side effect of PARP inhibitors, nausea, asthenia, and these are the most common side effects. And this was managed conservatively. So, so based on these data, rucaparib was used or approved for the maintenance of recurrent ovarian fallopian tube or primary peritoneal carcinomatosis. So conclusion is that PARP inhibitors should be considered as the standard of care in patients with high-grade ovarian cancer, BRCA mutated and HRD positive patients post chemotherapy in first line. If the patient has received in the first line treatment bevacizumab at least 3 doses, then as per PAOLA-1 trial, the HRD positive high-grade ovarian serous carcinoma patient, they should receive bevacizumab plus olaparib maintenance. And this is the maintenance of PARP inhibitors is not only seen in BRCA positive patients or HRD positive patients, even BRCA wild type and high LOH patients, they have good performance status. They have good PFS as per the aerial trials. And irrespective of BRCA mutated status, recurrent ovarian cancer patients, more than 2 lines of therapy, PARP inhibitors can be considered irrespective of the BRCA status as the maintenance therapy. In platinum sensitive relapsed ovarian cancer also, PARP inhibitors can be considered as the maintenance maintenance therapy after some form of chemotherapy or platinum based chemotherapy. Thank you so much. I'll be happy to answer any questions. Thanks a lot. Over to the Osmosis team.
Okay. Thank you so much for your talk, ma'am. It was indeed a deep understanding of the PARP inhibitors in ovarian cancer. Ma'am, what we'll do is we'll take the question as at the end, and let's continue with the session. Okay. So now I would like to welcome. We'll start with the panel discussion here. So our first panel discussion, the moderator for panel discussion for the case study presentation is Dr. Shushanta Kumar Paikre. He is a consultant medical oncologist at HCG Cancer Hospital, Cuttack. He is the moderator, and the panelist along with Dr. Shushanta is Dr. Abhijit Das. He is a clinical oncologist, an associate professor in the Department of Radiation Oncology, Sanaka Hospital, Durgapur. Then we have Dr. Gautam Santosh Panda sir. He is a consultant medical oncologist, Bakchi Shri Sankara Cancer Center and Research Institute from Bhubaneswar. Then we have Dr. Antara Sanyal ma'am. She is a consultant medical oncologist, Sparsh Hospitals and Critical Care Private Limited, Bhubaneswar. And another panelist we have is Dr. Shashanka Das, who is a consultant and medical oncologist at HCG Cancer Hospital, Kolkata. So with this, I would like to hand over the session to Dr. Shushanta sir, and you can start over the presentation with the first case presentation, sir.
Okay. Is my voice audible?
Yes, sir, you're audible.
Slides visible?
Yes, sir. The slides are visible. Yes. Requesting you to full screen the slide, show the slides.
Yeah.
Okay. Yes, sir.
Very good evening to all. Thank you to my ideas for these opportunities. Today, after very good elaborating discussion about PARP inhibitor by Dr. Jogmaya Patnaik, that recent advances in ovarian cancer, and it is very impressive. So let's review that discussion, the continuing that discussion. So we'll discuss the case-based discussion. So if you see how the ovarian cancer presents and how the course was going on, if you see initially, if you see the first line treatment, there is PFS of 18.2 months. There is a because of surveillance, we detect the recurrence very early. And there is a symptom, then we start second line PFS is 10.2, then third line, then fourth line, like that. Ovarian patient has multiple relapse, then after that, after many relapse, there is a bowel obstruction, and every time the PFS was decreased. PFS was decreased. So these are many drugs approved by FDA from 2014 to 2020, 30 new drugs. So we'll go to directly go to our case. We have a 50-year-old female presenting to lower abdominal pain and backache for 2 months duration, history of loss of weight, and there is in per abdomen in family history and past history nothing significant. Per abdomen there is a mass occupying in right in iliac fossa and hypogastric region, and so with these the patient was presented. So there is a right lower abdominal mass. So my question to Dr. Abhijit Das, how to evaluate this patient and what are the tests we will do?
So the initial blood test and initial routine blood test, the CBC, LFT, RFT, etc. And by obviously the markers and the CT scan. The CT scan products abdomen in the pelvis, because we need to diagnostic scan we have to do. And if we find in the CT scan that if there is abdominal pelvic mass as well as there might be CA and the CA-125 discrepancy or the CA-125 rise, we may go for biopsy or a laparoscopic guided biopsy, depending on the what kind of stage we are looking at.
Okay. So in ultrasound, that abdomen, there is a large SOL in pelvic extending to lower abdomen, pushing the uterus to the left side, likely neoplastic. So patient was diagnostic laparoscopy done at the center he was treated. There is the biopsy was done from omental nodule. And the intra findings were bilateral ovarian tumor, omental nodule, and minimal ascites. So the biopsy report suggestive of metastatic high-grade serous carcinoma, C125-219.9. And if you see the next question to Dr. Gautam, that what percentage of your patient had early and advanced disease at presentation? The stage 1, stage 2, and stage 3, stage 4. The one group is stage 1, stage 2, another is stage 3, stage 4. So what percentage of patient who has early and unadvanced disease at presentation to Bakchi Center?
Sir, basically, most of the patients are at advanced stage. So, out of the patients which I see in the OPD, approximately 75% are basically advanced stage. 20 to 25% they present with an early stage, basically.
Okay, 25% in early stage, that between stage 1 to stage 2, and stage 3, stage 4 patient
Most of
advanced
them are,
stage.
yes, sir.
Yeah, 75%.
Yes, sir.
Okay, thank you.
Yes, sir.
Same
Yes.
with, I think all panel will agree with that. Then my next question to how to further investigate to Dr. Antra, how to further investigate this patient. Patient undergone surgery and patient has bilateral ovarian mass, who is positive for malignancy with omental nodule positive for malignancy. Then how you'll further investigate?
So now that upfront surgery has not been done in this patient, and only CCT abdomen, I noted that there was a 15 into 5 centimeter mass. So definitely a CCT thorax to rule out any other metastatic site for this patient. And if the general condition of the patient is PS2 or 3, I would definitely prefer for an upfront neoadjuvant approach followed by induction interval cytoreductive surgery in this patient, sir.
Okay, we'll discuss this part later. The which cases we'll see the all the case. If you then next question arises: is there any difference between NACT versus adjuvant chemotherapy? Is there any
Sir, in
difference?
survival, there is no difference, but it is all about the
So
ability to achieve an R0 resection in
yeah,
any
yeah.
ovarian carcinoma patient.
So there is a data. There is not every case. If the patient surgeon agrees for the surgery, and there is a criteria we have to classify whether the patient is high risk or not a high risk group.
Of course.
Then if it is high risk, there is a some advantage. Otherwise, even if high risk cases, there is no difference. So even if she undergone the surgery, there is a no problem. So the thing is that the question is if the patient undergone surgery and patient has bilateral ovarian mass with omental positive, is a stage 3 ovarian malignancy. How to investigate further? That's the question to you.
Sir, first of all, my doubt is for a baseline serum CEA for this patient and an upper GI endoscopy
Yeah,
inadvertently, because
okay.
very unusual presentation with such large masses with only mild ascites.
Exactly. So you there is a bilateral ovarian mass. So we have to rule out GI malignancy, and we have to do CA also. That's the things. So, if the patient is ovarian malignancy, always there is a, other risk also that may be a hereditary breast ovarian syndrome is maybe the part of the hereditary breast ovarian syndrome. So we have to do other tests also. If you want to test, my question to Dr. Sasank, what are the genetic tests you prefer in like bilateral ovarian malignancy or any ovarian malignancy? Is Dr. Shashank here?
Yes, yes.
Hello.
Hello, am I audible?
Hello. Then
Yes, sir.
Hello.
Yes, sir,
that
you're audible,
question to Dr. Gautam. Dr. Shashank, are you here? So my question here we discuss because here is bilateral ovarian mass, and usually you have most of the patient presented with unilateral mass, but here is bilateral. We are suspecting any hereditary risk. Then what are the tests we want to do in this case? What are the genetic tests in your practice you are doing?
Initially do HRD testing and then followed by the germline.
Okay. The preference is HRD. If HRD the tissue is not possible, sometimes tissue is insufficient, then you will go for germline HRR or BRCA1, BRCA2. Okay. Then this is nicely responded by Dr. Shashank that HRD, if possible, we have to do HRD because it includes all that germline BRCA or somatic BRCA mutation. So we need HRD test if possible. Sometime our labs not that telling that tissue is not sufficient or the test may not undergone that tissue. It is so we can do germline HRR or germline BRCA, which is possible. In my opinion, we can do germline HRR so that we can do many BRCA like mutation.
Yes.
So yeah. Then then my question to Mr. Dr. Abhijit Das, that is what is the incidence of BRCA mutation in your clinical practice? If you see in day-to-day practice, what is your incidence? It is my question to all the panelists. They can share their experience that percentage of BRCA mutation because I think all the oncologists doing BRCA nowadays. So my question to Dr. Abhijit Das first. What is the percentage of BRCA mutation in his practice?
We are getting around less than 10% people having this BRCA mutations. So another baffling factor is that all of my patients doesn't even afford a BRCA mutation or a HRD. That is one issue.
Okay.
And we are getting almost less than 10% cases.
Okay. Dr. Gautam.
Yes, sir. The incidence of G-BRCA in the patients which I have seen in OPD is basically 25%, 22, 25% basically.
Hello, Gautam. Hello.
Hello. Yes, sir. Am I
Hello.
audible, sir? Hello.
Yes, Gautam, sir, you are audible, sir.
Hello.
I'm saying,
Hello.
sir, approximately 20 to 25%
Okay.
are G-BRCA positive, sir.
So, okay. Dr. Antra.
Sir,
I
we have a data from some hospital for the last 5 years, and we saw that around 29% of our patients were germline BRCA positive.
germline
As
BRCA. Then
compared to
HRD.
HRD, we have had only 3 or 4 patients for that.
Okay.
Yeah.
Only germline BRCA is 29%. It's
Yes.
quite big. So whatever the literature reported that it's quite okay. Then to Dr. Shashank.
Yes, around so Dr. Gautam has told that around 50% have germline BRCA mutation, and
Okay.
HRD, as per the literature, shows around 50% of the ovarian cancer patients have a HRD positive.
Yeah. So we have this patient who is operated that with bilateral ovarian momental met stage 3 ovarian malignancy with the biopsy proven that high grade serous carcinoma and upper GI lower GI endoscopy normal, CA normal. So we have diagnosed case of ovarian malignancy stage 3 with complete cytoreductive surgery with BRCA mutation in 50-year-old female. There is no significant family history. Then my question to all the panelists that how to manage this case. The first Dr. Abhijit, then Dr. Gautam.
Yeah, I will choose this patient for at least 5 to 6 cycles of the paclitaxel in the carboplatin. I will also like to know that if this patient is BRCA mutated, we can always give a
No,
maintenance
it is a
olaparib.
BRCA1 mutation positive,
Okay,
germline
then we will
mutation
give a
positive.
olaparib maintenance as well.
Olaparib maintenance.
Yes.
You want to add bevacizumab in paclitaxel carboplatin?
If this patient has a complete resections in the laparotomy, then I will probably.
Okay, okay. Dr. Gautam.
Yes, sir. So, patients who are basically, hello,
Hello.
sir. So,
Yeah,
patients, yes, sir. If it is BRCA mutated, GBRCA mutated, I generally start with the peclicarbo, followed by IDS. If it is done, then adjuvant chemotherapy, that is completion of chemotherapy, followed by maintenance olaparib.
yeah, definitely. Yes.
And if it is BRCA, GBRCA negative, HRD positive, the options are being basically peclicarbo plus bev, followed by after completion of the treatment, basically bev plus olaparib as the maintenance, or the rucaparib are the basically options.
Exactly.
Basically.
Very good. Dr. Sasank, what is your approach? Is same as all panelists, like paclicarbo followed
Yes,
by
technical carboplatin, cycle
olaparib.
followed by
Yeah.
uh,
Definitely, because the cytoreductive surgery was done, but if surgery was not done, there is a many other opinion also, like Dr. Antara told that she may give paclicarbo with bevacizumab or plus or minus like that. There is a we'll discuss that part also. So she
Shashank,
underwent surgery,
like
THBA,
to
myomectomy,
add something.
optimal cytoreductive surgery done. She was referred to
Shashank sir,
all the other things are discussed.
I would like
The
to add
preferred regimen
something.
already discussed. Then the point here is one thing here is want to discuss to Dr. Antara. I think she is interested to tell because now she completed her DM and a lot of academic knowledge. Then she can highlight whether to give intraperitoneal chemotherapy in this case or not. Then what is the data you want to tell support and against?
So first of all, I wanted to say that since this patient is germline BRCA positive, so
Mm.
definitely bilateral sonomammography or bilateral MRI for this patient has to be offered
Yeah,
upfront.
definitely.
And if possible, definitely will offer risk reducing mastectomy at the time of primary debulking surgery itself. It
Mm.
will help us take care and reflex familial testing of all the sons and daughters, if any. And regarding, sir, your question for intraperitoneal chemotherapy, first of all, when we look at the data, so a majority the European and American data, they are very comparatively different. So European people, they prefer operating patients upfront, and intraperitoneal chemotherapy they like to give. But when we look at the American data, they prefer giving neoadjuvant approaches followed by interval debulking. And intraperitoneal chemotherapy, it is usually, sir, preferable in patients who have undergone a complete R0 resection, HIPEC for those in the interval debulking surgery. Even though the data is still not mature enough, I would say that it should be offered to patients who have relapsed, because in those patients we don't
Mm.
get another chance of
Yeah.
a debulking surgery again.
Yeah, definitely. Dr. Sasank, in your center, you are practicing intraperitoneal chemotherapy. Those are
No,
no. Dr. Gautam, in your center, Bakchi, I think a very advanced center in our city.
Yes, sir.
Intraperitoneal
We have done
chemotherapy
basically CRS and HIPEC also.
in which patient upfront, like Antara told that in
Not
relapse
upfront,
setting
sir.
they
It's
are preferring.
not relapse, sir. It is basically for the primary cases who are basically planned for IDS after NACT basically.
Okay. After NACT, not upfront, like surgery followed by IP
No,
intraperitoneal,
sir, not
there,
upfront, sir. And
not
for
upfront.
upfront, there is no data also actually for HIPEC.
Now, what
So,
is your comment on GOG 172? This
yes,
is
sir.
told that the OS is for 65.6 month in IP group versus 49.7 with p-value 0.03.
Yes, sir. There is definitely the benefit is there, but in addition to benefit, there is also a lot of toxicity which is also there. So you have to
Yeah,
take into
definitely.
consider that also.
Okay, okay.
So it
Dr.
should be
Abhij,
selected in few patients, but not all the
yeah.
patients who are
But
coming.
in your
Yes, sir.
opinion, that in your center, you are not practicing IP chemotherapy. Okay,
No, sir.
that's
No.
in upfront cases. Okay,
No,
and
sir.
mine
No.
also same. And every panelist, every medical oncologist agree that we are not practicing. We are not sending our patient upfront for the IP chemotherapy because of the tolerability issue. There is a toxicity issue. Dr. Abhijit, what is your opinion?
Yes, yes, yes. Because of the toxicity issue,
Yeah,
I will not.
definitely. All the because it is if any surgical oncologist is there, then will be discussed will be more interesting because their point we have to give IP intraperitoneal chemotherapy, but not always possible. Not all centers are equipped with HIPEC. Okay. Next, this, then coming to question to that thing, Dr. Abhijit, that what about dose dense chemotherapy regimen in ovarian cancer, and what should be the dose and what are the benefit?
Dose-dense systemic regulators actually have been used in trials, but there are a mixed data. Actually, some are positive trials, completely negative trials. And so, as like you have shown here, that JGOG, that initially uh, the the weekly dose dense is better, but the
Oh,
problem is there are other trials which are not that good, and we also have to think about the QoL issues, the quality of life issues. So
yeah,
I am not practicing dose dense currently.
yeah. You are practicing 3 weekly paclitaxel.
Yeah, it's standard 3 weekly.
Dr. Gautam, Dr. Gautam, what you practicing in your center, weekly or 3 weekly?
So basically, sir, if the patient is frail or elderly and not fit for 3 weekly chemotherapy, I generally start with the weekly. And if the patient is fit enough, I generally start with the 3 weekly basically.
Then what is your dose there? Because in this trial, GOG trial, they are telling the weekly dose dense is very much toxic than the 3 weekly regimen. So in elderly, the frail patient, if you give dose dense, then there may be problematic. Then what is your dose is there? Whether you give every week or there is any gap?
So I basically give 3 weekly, then 1 week of gap, then I continue the same treatment.
Then what is the paclitaxel dose and the carboplatin dose there?
Same, sir. Paclitaxel will be 80 milligram per meter square. Carbon will be 82 basically.
Okay. And then there is in between there is 1 week gap
1 week.
after
Yes.
3 cycles. Okay. Dr.
Yes.
Antra, what is your approach?
Sir, we prefer for all the patients for weekly Pacli. So the Japanese, this group of patients received 80 mg per meter square, and we practice that only, sir. And carboplatin we usually prefer for OC4 on day one.
Every patient you are practicing weekly?
Yes,
The
sir, we
patient
are.
able to come in every week?
Sir, those patients who are able to travel definitely. So patient GC also matters a lot. So it is possible to give the patient weekly. At some we were practicing at Spurs as well. We are practicing the same.
Okay, okay. Preference is weekly, and if patient didn't agree, then second option is 3 weekly.
Of course.
Then it is paclitaxel 80 mg per meter square weekly. There is no day 1, day 8, day 28 also.
Day 1, day 15 we give, sir.
Then there is 1 week gap.
If 1 week gap, then again day 1, day 15.
Okay, okay, okay. That's okay. Dr. Shashank.
Yes, as Dr. Gautam has told, if the patient is frail and unable to tolerate 3 weekly regimen, means paclitaxel, then I also prefer a weekly 80 mg per meter square paclitaxel with AUC2 carbo. Day 1, day 15, 20, every 28 days. Otherwise, the standard 3 weekly I prefer for most of my patients.
Okay. Here, I think we have to go through this trial, but here they are giving weekly, I think every week. I think day 1, day 8, day 28, I think the GOG trial. And here
They
they
gave it
giving,
day 1, day 15, then 1 week
huh?
gap. Yes, sir. They gave it day 1, day 15.
Hello. Hello.
Yes, sir. Yes, sir. They gave
Am I
it day 1,
audible?
day 15. Yes, sir. You are audible, sir.
Hello.
Shushansa sir, you are audible, sir.
Yeah. No, Dr. Antara want to focus something.
Oh, no, sir. I was agreeing with you. They
Yeah,
did
yeah.
give it day 1, day 15 karke in the GOG trial.
Yeah. So what happened in this trial? There is a definitely PFS and OS benefit, but the tolerance is the issue, and those are there is a residual disease at least less than 1 centimeter. There is optimal debulking. Optimal debulking, there is no significant difference. If there is a suboptimal debulking, in that case, dose dense was more is benefited. Another is, if you compare another trial is paclitaxel 60 mg per meter square weekly, then there is no benefit. So if you want to use dose dense in a fit patient, and then there is the dose is paclitaxel 80 mg per meter square, carboplatin 3 weekly dose. So next. So then coming to question that initially we discussed that part of the bevacizumab, adding bevacizumab, which case will add, which case will when the bevacizumab benefit. My question to Dr. Abhijit, is there a benefit of adding bevacizumab PFS or OS benefit?
Basically, if any patient who is having a cytoreductive surgery upfront, or say, which is like R1 or R2 resection, and or there is a pleural effusion being positive malignancy, then there are studies where basically adding bevacizumab will help, and in those cases also it has to be a bevacizumab maintenance as well. So like the ICON trial and the GOD trials, but it's not applicable in all cases. So
Yeah.
a few patients, there are subset where there is a high risk, like pleural effusion positive, ascites being malignant, and there is a high chance if you do a upfront surgery, the patient will end up in the R1 or R2 section. And then probably we'll add OSG1 and that will have a PFS benefit.
Yeah, definitely. Dr. Shashank, what is your opinion about adding bevacizumab with paclicarbo? In every case, you are advising the bevacizumab in your practice, or you have to select some cases to add bevacizumab?
If I'm giving a NSCT, I usually prefer in a patient of advanced stage with ascites, peritoneal disease, momental disease, pleural effusion. So mainly in the stage 3 and stage 4 disease, I prefer. If the patient is operated upfront, then in case of only the patient is having a R1 resection, I add bevacizumab.
Dr. Gautam, what is your dose of bevacizumab if the high risk patient ovarian malignancy? What is the dose?
Sir, I generally use 7.5 milligram per kg, sir.
Yeah.
Every 3 weekly.
Okay. Is there any is there any advantage of adding that is where the dose of 15 mg per kg?
Sir, truly speaking, I have not used 15 milligram per kg,
Yeah.
but the toxicity basically goes up when you go to 15 milligram per kg. I've been using 7.5 milligram per kg only, and there are trials which have shown the efficacy of 7.5 milligram per kg is equivalent to
15 mg per kg.
15
Okay.
mg per kg. And in GBM in the neuro also they've shown that 5 milligram per kg also is equivalent to 7.5 milligram per kg.
Okay.
So I have not used basically 15 milligram per kg as of now.
Dr. Antara, any difference in opinion, the dose about bevacizumab and the maintenance schedule?
No, sir. Actually, since we don't get primary debulking surgery while a patient, so it is very difficult to add paclicarbo-bev in the adjuvant.
There is
But,
many cases of primary debulking. The surgeon sending to us after
but the
debulking
majority
surgery.
patients, they come in PS3 status, so it is quite difficult to go for. And there is no role of bevacizumab in neoadjuvant. And all these trials.
You are talking that neoadjuvant setting. We are discussing adjuvant setting.
No, sir, I'm talking about adjuvant setting only. I'm saying there is no role of bevacizumab in the neoadjuvant setting. And if we were to say give 3 cycles of paclicarbo, then the patient was to undergo an interval debulking surgery. Then also there is no data that whether we can add bevacizumab in the next 3 adjuvant cycles or not as well.
There is a
So
data,
this,
I am showing that GOG 212, there is a data to analyze. There is a data.
but
Then
sir,
after.
but none of those patients benefited, sir. In this GOG 218 and the ICON 7 as well, all the patients that post hoc analysis showed was that patients who had a high risk group, who had an R1 or R2 resection, like Dr. Abhijit said, that they were the only ones who actually benefited from it, had any PFS benefit. Otherwise, all the patients did not derive any benefit from them, sir.
Yeah, definitely. That there is a data. I have to conclude this bevacizumab adding bevacizumab. There is a PFS benefit there. This is the 3 arms, the paclitaxel carboplatin, placebo plus paclitaxel carboplatin plus bevacizumab. Second arm, another arm is paclitaxel carboplatin, bevacizumab followed by bevacizumab maintenance. So that PFS benefit is there. That is 10.3 versus 14.1. That one thing is that there is no OS benefit. So if you see that data, if you see there is if you analyze final overall survival, that is in stage 4, the with bevacizumab is 42.8, and another is in stage 1 is 44.3. So OS for stage 4 control 32.6 month in control arm, and if you add in stage 4 bevacizumab group throughout 42.8 months. So if there is a FIGO stage 4 disease may derive some survival advantage from bevacizumab. So when you adding to want to add bevacizumab, then you have to see the what is the stage and what is the bulk of the disease, the ascites, mental load. So we have to see that part so that we can decide whether that patient needs bevacizumab or not. So this is the ICON 7. Then I want to highlight something in this study that they in ICON 7 they analyze high risk patient, the planned subset benefit. There if you see there is a benefit in PFS and the OS also there is a benefit. So if I conclude after this data, the bevacizumab needed in the high risk ovarian malignancy than the low risk group. And another thing is in every ovarian malignancy, there is a median that is PFS benefit, but not OS benefit. So we have to plan our group to add bevacizumab. So we all the things discussed. So the time is short. So patient received 6 cycles paclitaxel carboplatin, and patient is HRD positive. Every panel agree with that. If the patient is HRD positive, BRCA wild type. So my question to Dr. Abhijit, what is the choice? HRD positive, BRCA wild type.
Yeah, so as of now, there are 3 choices possible.
Maintenance treatment.
Yeah,
I am asking maintenance treatment.
Yeah, maintenance olaparib bevacizumab combination, or the rucaparib or the niraparib, we can give as a maintenance therapy in the first HRD being positive and the BRCA wild.
Dr. Shashank, HRD positive, BRCA wild type.
In HRD positive, we can give either the olaparib or rucaparib. As I'm not using the bevacizumab in this case, so I will be using only the olaparib or rucaparib.
Yeah, absolutely right. Dr. Gautam. Dr. Gautam is here. Dr. Antra, want to tell HRD positive, BRCA wild type.
HRD positive BRCA wild type, I would like to either go ahead with the olaparib, rucaparib, or niraparib, preferably olaparib. But for the HRD negative BRCA wild type subset, definitely I have more experience with rucaparib, so
Yeah,
I would like to go ahead with rucaparib.
already that there is a data that supports us. If HRD negative, then we have to give bevacizumab olaparib. But if it is positive, then the rucaparib is the choice because it is available with us, rucaparib. So this is the summary of the data, all the discussion, and how on the study, how the studies are supporting all the trial, all the drugs, the different drugs, the olaparib, bevacizumab in the HRD negative patient, then Paula 1. They are using all the group, but if you see the olaparib, bevacizumab, if the HRD negative, rucaparib alone in HRD negative Athena mono trial. So this is the study. These are the studies supporting the use of the first line maintenance treatment in different setting. So this is already discussed. These are the rucaparib was approved by NCCN and European guideline in both the HRD positive, HRD negative, mutation negative. Wild type. My opinion is in wild type, rucaparib was approved by both the NCCN and European guideline, and olaparib and bevacizumab also approved for the HRD negative population. Niraparib, though it is approved, but it is not available in our country. So we are more friendly with olaparib and rucaparib drugs because the drug is not simple. There is a lot of side effect because one of my patient I have to stop olaparib because of the frequent anemia. She is BRCA mutation positive, but every time patient has anemia drop to 5, hemoglobin 5. But one of my patient completed olaparib and rucaparib. Few patients are completed rucaparib and olaparib for 2 years. So there is initially there is a tolerance issue. So we have to more you have to assess the anemia part, the nutritional part, whether the patient any pre-existing myelodysplastic syndrome, whether the patient having any anemia, undergoing iron deficiency anemia, or there is a megaloblastic anemia. So we have to more take, but we can't do in the all patient. But preferably be patient the hemoglobin is lower side. We have to evaluate the nutritional part. So already discussed that HRD negative BRCA wild type, we have to give rucaparib or bevacizumab olaparib. So this is the patient was positive, pathogenic mutation BRCA1 positive. Then already with that, all the panelists agree with that. We have to give PARP inhibitor as a maintenance if the patient BRCA1 mutation positive. So no doubt about that. So so with this, I thanks to my panelists give their opinion about all the management of the high risk ovarian cancer and the recent advances, moreover PARP inhibitors. And there is little bit confusion. We are not discussed about the NACT part, but I agree with the panelist that if the patient has high risk, PF is not good, then we can give some weekly that we can weekly paclicarbo if and we can add bevacizumab if patient the condition health condition allows. There is no the comorbidity. There is no contraindication for bevacizumab, then we can add bevacizumab to give the rapid response. Though there is no OS benefit, but there is a response rate is very high and response is early. So in that case, we can improve. After that, we can go for interval debulking in the NACT part. So with this, I conclude the session because we have to go for next session. Thank you. Thank you so much to all my panelists.
Thank you, Dr. Sushanta, sir. It was an excellent case presentation, as well as all the panelists for a very insightful discussion. It was very highly informative. Okay. Now, I would like to request we move ahead with the second case presentation. So, our second case presentation, the moderator for the second case presentation is Dr. Joydeep Ghosh, who is a consultant medical oncologist, Apollo Galangiel's Cancer Hospital, Kolkata. Along with Dr. Joydeep Ghosh, the panelists who will be joining him are Dr. Anish Das Gupta, who is a consultant medical oncologist, Narayana Hospital, Kolkata. Dr. Lipsita Samanthare, who is a consultant medical oncologist, IMS and SUM Hospital, Bhubaneswar. Dr. Sumit Avo Ghosh, who is an assistant professor and consultant radiation oncologist, Sanaka Hospital, Durgapur. Dr. Tamizoli Selvaraju, consultant clinical and radiation oncology, Barpeta Cancer Center, Barpeta. And last, Dr. Amitabh Upadhyay, who is a consultant medical oncologist at TMH Jamshedpur. With this, I would like to hand over the session to Dr. Joydeep Ghosh, sir. Dr. Joydeep Ghosh, sir, you can continue your session.
Yeah, thank you. So I think you had quite an extensive panel discussion. So since we're running short of time, I will be very quick.
Sorry to interrupt. Will you share your slide or do I need to share from my end?
I'm sharing my slides.
Okay, thank you.
Okay, so I'll be quick. Most of the things have already been discussed. I hope the slide is visible.
Yes, sir.
Okay. So let us take this case. The slides have been provided by Samar. 69-year-old female presented with left cervical lymphadenopathy and sought medical attention December 2020. Gynecologists could not find a gynecological reason for this, and no significant medical history findings were noted. Imaging was done, as you can see on the right side. I'll just show here. Multiple cervical lymphadenopathy, also multiple pelvic region lymphadenopathies, and there is a uterine leiomyoma, but with no other tumors of the digestive tract. Anyways, there was a PET CT done, which revealed an uptake in the left supraclavicular, left axillary, left para-aortic, and left external iliac nodes with no significant uptake in any other organs. So my question would start with Anish. So in this kind of this I would call it as a carcinoma of unknown primary. So what are the workup that you're going to plan?
Sir, in this patient, as we can see that there are multiple lymphadenopathies. So I would like to get some tumor markers done and a biopsy from the most accessible site, either the axillary or the SCF node. And we can run a panel of IHC on them to find out the probable primary. So then based on the tumor markers also, we can take a better approach to the IHC.
Right. And considering the way the disease is, it's mostly nodal. Yes. Rather, it's exclusively nodal.
Yes, sir.
So chances of a lymphoma is very high.
Yes, sir. That will be very high.
Yes. So a good core biopsy, or if possible, an excision biopsy will be the way forward. Okay. So histopathology showed moderate to poorly differentiated adenocarcinoma. So slight change in the story. So my question to Dr. Lipsita would be, so what would you want to do next? So lymphoma is ruled out. It's an adenocarcinoma, poorly differentiated. What more do you want? What more information do you want?
Sir, on the cervical lymph node showing poorly differentiated adenocarcinoma, to
Right.
differentiate which type of adenocarcinoma it is, we have to go for IHC panel.
Right.
It could be, since adenocarcinoma, it could be GI, it could be lung, it could be anything. So,
Okay.
IHC panel would help us along with tumor
IHC panel would
markers.
help us. Perfect. I totally agree with that. Somehow, somebody did a CA125 which was elevated, and IHC was also done. So you can see that it was positive for CK7, negative for CK20, positive for CA125, partially positive for PAX8, and partially positive for ER. Dr. Thamizoli, any other IHC you want, or you are comfortable with this panel?
Yes, sir. I think keeping in the background of CA125 is also elevated. And the IHCs goes in positive of CA125 and partially positive of PAX8 and ruling out the lymphoma marker. I think we can proceed. I mean, in terms we can narrow down or presume.
I think in addition to that, maybe a WT1,
yeah, WT1 might help.
and a TTF1 would be useful,
yes,
because
breast
that would rule out a breast and the lung
breast
and an endometrial primary. Right.
Exactly.
Okay. So breast examination, no tumor was found. So this case was considered as an occult ovarian and fallopian tube cancer based on the pelvic lymph node swelling and the results of IHC and elevated CA125. And because of the presence of cervical node, obviously surgery is out of question. So my question to Dr. Amitabh Upadhyay, have you faced any case in your practice which is like an occult fallopian tube or ovarian cancer where you did not get in the primary, but in the radiologically, but otherwise it's very much fitting in with the ovarian cancer? Any such experience?
Yes, sir. This is quite unusual presentation, and I have treated one case when I was in Chandigarh. So that time the patient had almost similar presentation. So
Yes,
it was
I also
treated
have
like
same.
unknown primary, and just like your slide. So finally, she underwent surgery. She after the interval NSCT, she underwent surgery. And at the time of surgery and histopathology, we could find very small foci of this serous in one of the ovaries, although the imaging was not showing anything in the ovaries.
Right. Yeah, so this is a very, very rare presentation of an occult ovarian primary, and this case tells us the importance of doing a comprehensive immunohistochemistry to pinpoint the. Shumita, any role of doing NGS in this biopsy specimen, either to look for primary in the form of gene expression profiling or any other utility? Would you go for NGS?
Sir, we can go for NGS, but in my opinion, the clinical history is also very important here, because we have to rule out the presence of any family history of the cancers in the first degree relatives.
Right. So this patient was somehow started on treatment with the combination of taxane, platinum, bevacizumab, 4B histopathologically fitting in with ovary. So based on the present evidence, they were started. And CA125 progressively came down to almost less than 15.8. And then the patient was, I suppose, continued on. Yeah, so all the lesions revealed a significant reduction in the size after completion of 6 cycles of chemotherapy. And the CA125 is normal after 1.5 months of taxane, platinum, and bevacizumab. So coming back to Anish, so what are the tumor markers you need to decide your treatment? What other biomarkers? BRCA would you want to do in this patient?
Sir, I would have done the BRCA upfront, BRCA and
Right.
HRT upfront
Upfront
before
BRCA.
starting the treatment.
Right. So family history, this seems to be a strong family history. It revealed esophageal cancer in the patient's maternal uncle and breast cancer in her daughter and her maternal uncle. So very strong family history basically. And there is a BRCA1 gene in this particular person. So the accumulation of breast cancer was indicated to be apparent in the maternal lineage, and HBOC syndrome was suspected. Genetic testing for BRCA variants was performed in June and we detected a germline variant in BRCA1. And consequently, the patient was also diagnosed as a HBOC syndrome. And the treatment was followed by maintenance therapy with PARP inhibitor olaparib due to platinum sensitivity maintained with chemotherapy. So PARP and bevacizumab would be continued. So, Dr. Lipshita, in your practice, would you suppose you have started the patient on PARP inhibitors? Suppose you have started the patient on taxane platinum plus bevacizumab, and in due course of time, you see that the patient is having a BRCA1 mutation. So in the maintenance phase, do you stop bevacizumab and just continue the olaparib, or would you want to go ahead with the continuation of bevacizumab and olaparib? What do you normally do?
Sir, if bevacizumab was already given prior to maintenance, I would like to continue with olaparib.
Based on the Paula study.
Yes, based on Paula
Right.
study.
Right.
The financial constraints and all that.
Yeah, we'll keep aside finances. So yes, I would agree with anybody has a difference of opinion. If you find a BRCA1, would you want to stop bevacizumab? Anybody has any difference of opinion? Okay. So this patient was discussed with I think in a board meeting, and patient underwent a bilateral salpingooprectomy, total hysterectomy, partial omentectomy through laparotomy approach as a part of the risk-reducing salpingooprectomy. Now I would come to Dr. Upadhyay. So this is a situation that we commonly would face, not commonly, but sometimes one-off, where suppose you have a fantastic response, there is a complete remission in the CT scan. CA125 is normal, but the patient is BRCA1 positive, very anxious family, strong family history. So in a metastatic setting with the 4B disease in situ, would you recommend going for risk-reducing surgeries? Or you say, okay, you're not going to survive long, so what is the point?
Sir, very prudent question. So, first of all, we should understand that the risk reduction, the concept of risk reduction surgery arises only if you are expecting a good survival, around 10 years to be very precise. So, in the cases of breast cancer, where we expect a 10-year survival of say 70-80%, we offer bilateral salpingooprectomy as a part of risk reduction surgery, and obviously opposite side mastectomy. But vice versa is not true. Suppose we are treating a case of CA ovary, so we are not expecting a 10-year survival. So in those cases, the option of offering mastectomy is a debatable thing. But obviously in your case, since we are dealing with the unknown primary, then surgery was a very good option, and you couldn't find anything. But in my case, I found a small foci of tumor. So we cannot say it's a risk reduction surgery. One of the intent of surgery could be to finding a occult hidden foci of some residual disease in ovaries also.
Okay. So coming back to the case, the pathological examination of the specimen did not reveal any evidence of malignancy. So the primary ovarian cancer origin was presumed to have completely disappeared, and since then the patient continues to be on olaparib treatment. Lymph nodal metastasis in the left supraclavian, all these regions have decreased to nearly insignificant level. So I want to ask Dr. Thamizoli that in such a situation where you have a fantastic response to olaparib, 4B first line upfront, so I suppose you will be stopping the olaparib at 2 years, or you would continue it till progression for indefinite period. Dr. Thamizoli, are you there?
So Dr. Tamizoli is not there.
Okay. So, Anish?
Sir, I think as we are treating this patient with a curative intent, basically, so we may stop at 2 years.
Right. So suppose you had a patient who's not been treated with a curative intent, say for example extensive disease and all those things, but there is a very good response, complete remission. So you stop at 2 years or you continue till progression? What does the data say? Dr. Lipshita, any difference of opinion?
But in both the cases, I would like to go with only 2 years of laboratory.
Okay, okay. So this patient was, let's see, you can followed up with CO125, remained in the normal range, and she was also undergoing regular breast screening. Is obviously 70-80% chance of developing a breast cancer. So with that, I will conclude the panel discussion. Over to the organizers for their comments. Thank you, my panelists.
Thank you so much, sir, for a comprehensive case presentation and also a very good discussion for the same. Now, there are some questions which are there, which I'd like to ask to Dr. Jogmaya ma'am. As it is, Dr. Jogmaya ma'am has already answered it, but for the audience who are watching us live, I would like to ask the question to Dr. Jogmaya ma'am. Ma'am, are you there? Dr. Jogmaya ma'am?
Anjana, you can speak out the questions as well as the answer. No problem.
Okay, so the question is, what's the reason that PARP inhibitors are working in BRCA wild type patient also? So a wild type patient also. So Dr. Joydeep Ghosh, would you like to answer this question?
Anyone from the panel, if you can
Would like
request
to
you.
answer this question? Yes.
Yeah.
Yeah, may I come in, Dr.
So,
Mehta?
Yeah, sure, sir.
yeah, please.
So
Thank you
it's
very
a
much, sir.
very good question, actually. So we can see the approval for wild type is only for niraparib, truly speaking. And if you deep dive into the data of niraparib, so you can see that for obviously for BRCA positive, HRD positive, there was a very significant and clinically meaningful survival advantage. But you go to the subset of the patient who are actually BRCA or HRD negative. So the difference is survival is just 8 months versus 5.4 months. So though they have the approval, but I strongly believe that this is kind of the data is biased because of they have taken the approval on the basis of overall benefit in overall subset of the patient. Similarly, for the this rucaparib, so Athena study. So for HRD negative subsets, the specific subset, the difference in survival was 12 versus 9.1 months. So again, there is some benefit, 3.1 month benefit better than niraparib. And for other studies also see this Paola 1. So Paola 1 study, if you deep dive into the subset of HRD negative or unknown population, so there was absolutely no difference, 16.9 versus 16 months. So though the question is good, we can offer, but as a clinician, we should be very skeptical in starting olaparib or any targeted therapy, any these PARP inhibitors for BRCA or HRD negative subset of the patient. Yeah, definitely in the second line and beyond, we can offer these treatments. Thank you.
Thank you, sir. So there is one more question which is asked by Dr. Sen Roy. Her question is that antibody drug conjugates, which are also known as ADCs, have shown promise in the treatment of ovarian cancer. They allow for targeted drug delivery to the tumor cell, and thus they may have less toxicity than standard chemotherapy. So can we have this therapy used in combination with PARP inhibitors? What are your opinions on this? So I would request any one of you who could answer this question by Dr. Debolina Sen Roy. Anyone? Dr. Sushanta, sir, would you like to answer this question?
Actually, the conjugate there is here, but I don't think there is any data with PARP inhibitor. And the antibody conjugate in the exactly the name is I am not remembering that, because we are most of times, even if without PARP inhibitor also, ovarian malignancy overall survival after many recurrence also there is 3 to 4 years.
Okay.
With PARP inhibitor, the overall survival increased to another 2 years.
Okay.
Okay, so one of my patient with recurrence also with rucaparib, the patient was surviving. Now is completing 2 year. After completing 2 year also, after 1 year of disease-free survival, patient is still surviving. So with this advent of PARP inhibitor and all the things, I don't think we need any drug conjugate to add with PARP inhibitor. So that very early to comment. Near future, many data is coming with antibody conjugate in the platinum refractory patient, and in the platinum refractory, that no load of olaparib. So in platinum refractory, in that case, we may use that antibody drug conjugate drugs, but not in the platinum sensitive disease.
Okay. Okay. Thank you so much, sir. Now I would ask our the marketing head of Samarth Life Sciences, Mr. Saurav Saha, to please end the meeting with his closing notes.
Thank you, Anjana. With that, yes, we have spent a good time, all of us, with a lot of questions answered, and during the panel discussions of the ovarian cancer of the two cases. Special thanks to the entire team, especially Dr. Sushanta and Dr. Jaideep Ghosh. And at the same time, we also have a special panelists like Dr. Abhijit Das from Durgapur, Dr. Gautam, Santosh Panda, Dr. Antara Sanyal, Dr. Shashanka Das, Dr. Anis Dasgupta, Dr. Lipsita, Dr. Sumitavo Ghosh, Dr. Amitavo Upadhyay, and so with this, I would like to thanks to all of you for coming for this osmosis. We have a live attendees of 210 who is observing and who is getting the insights and the feedbacks from all of you. With that, I'd like to congratulate to all of you, the entire Samarth team, for the successful Samarth osmosis for conductions, and at the same time, I also thanks to the backhand team, the Mice Ideas, for their nice organizations and conducting this event in this platform. With that, I'd like to close and thanks to all of you again. Thank you. Good night.
Thank you. Good night.
Thank you. Good night, everyone.